AIOS, Professor Namrata Sharma, and Chatra for getting me this topic. I think this was a wonderful session which we had, and my talk is little on a different side. But being a clinician does have a significant role in customization of any procedure. That holds true for a cataract surgery also. And Interop OCT has given us a new thought, new thinking, new vision, a new way to look into a cataract surgery for our patients and for research and patient care and teaching also. You all know the principles of optical coherence tomography, and basically it is a low coherence interferometry based on a Michelson interferometer, where a time delay and intensity of infrared light reflected from the tissue structure against a reference beam will give you an interference pattern, and that will lead into cross-sectional image of tissue of interest. And it gives you multiple A scans combined into a composite two-dimensional image as D scan for our patients. As far as Interop OCT is concerned, which are attached to the microscopes, we had earlier handheld devices also, but the new devices which are attached to microscope, surgical microscope, gives you a totally different dimension of doing a surgery in our patients. So basically, it gives you an in vivo optical biopsy of structures which you are dealing with. And apart from that, it gives you the dynamicity which happens with each step of your surgery during your intraocular manipulation. So it helps you in a diagnosis on the table, which may comprehend your diagnosis which you have done pre-operatively by slit lamp or anti-segment OCT of those patients. And this diagnosis intraoperatively will give you a new planning, new customization of surgical steps for your cataract surgery, and also help you in a decision making at that particular moment in each step of surgery. And you can monitor what is happening during your surgery also. So these are various commercially available IOCT systems, both handheld and the microscope attached. And in looking at microscope attachment, we have three companies, Harkstide, and you have Carl Zeiss and your Baptogen. All three have a similar range of capturing the images and give you almost similar way of handling these patients. I have experience of Zeiss Rescan 700, and when I thought about this, how to prepare this talk on a customization or sort of Interop markers for a cataract surgery of patients, I divided this into three classical areas. The one would be a routine cataract surgery, a routine phacoemulsification. What are those areas where this IOCT will help us in customization of our surgery? Then we have a challenging cases where IOCT would help in modifying, in achieving the surgical outcome which is required for our patients. The third was phakic intraocular lenses, because when we started using IOCT for retina and cornea purpose, the first thing we realized was how can we measure this depth in these cases, and phakic eye was one area where we could do that. So in looking at the routine phaco, incision one area which really gives you the initiation of a surgery, and a lot of things happen making the incision distortion during the surgery and after completion also. And it can give you a visibility of things which are not visible, like especially looking for a descemet membrane detachment in the incision area also. Then other important area in cataract surgery which are not visible is your hydro procedure, because hydro procedure changes your surgical steps totally in a different manner. Then intraocular lens, which we never had the visibility where the lens was resting. What is the dynamicity of intraocular lens as relation to the posterior capsule when you implant? Can we assess the tilt, its position during your surgery when you make the chamber tighter or loosen the chamber? And same thing which I'll cover in the challenging cases also, especially wide cataract and posterior polar cataracts. So first, this was our survey article recently published where we highlighted all the advantages of using Interop OCT in cataract surgery, which really gives you a real-time visualization of ocular structures during surgery, and the dynamicity with your instrument and your surgical procedure happening in those cases. So these are four areas I'm going to cover today. And first thing was when we started using this device with earlier generation of Interop OCT with GIS, didn't have the caliper to measure the depth. So we started using in a faking intraocular lenses where we could measure the intraoperative bolt. In fact, this is one of the first publication in the literature where you could use this system to actually measure the intraoperative depth of a bolt of ICL lenses. And that gave us a clue how we could measure. So we could make the parameter to see how much is the depth by changing the microns of Callisto system, which is normally 2000 microns is the height of Callisto. And that will change the millimeters to see the actual depth, and we subsequently compared with the post-op anti-segment OCT, and it was very, very reliable. And the factor we got was 7.5 if you multiply the millimeter distance from the posterior surface of ICL to anti-surface lens in millimeter. That will give you actual depth assessment. If this was a 265 millimeter depth we could achieve in the case of 2000 micron, which is the actual height of Callisto system. With the new high definition rescan 700 now, it has the device to measure, which has 5 segments of 1 millimeter each. If you take this, you can actually measure the height or a thickness of cornea, which we normally use nowadays for all corneal procedure. We can measure the thickness appropriately. Let me come to the cataract surgery per se. Incision, how we look into incision and customize them. We can look for a planar type of incision. The other area which I have worked was a distortion happening during each step of a phaco surgery, and assess its dynamicity with the various procedures, and subsequently look for any wound side decimal detachment which can be actually calibrated as per the visibility there. So this is a single planar incision which we could, and this is a biplanar incision, and this is a triplanar incision which is normally can be achieved in a femtosecond devices. So this is what we compared, and we realized if you have a good incision to begin with, you have a lesser chances of distortion. And femtosecond incisions were actually triplanar, and we had lesser DMD in these cases as compared to the blade created incisions. And the wound side decimal detachment could also be graded in terms of millimeters. And subsequently, we worked on other areas of incision, which I'll cover subsequently. Second was looking into hydro procedures. We classically teach our students what is the completion of hydro dissection or delineation. We'll always say there will be up bulging of a lens diaphragm. There will be a decrease in the glow, and you can see the peripheral rings of a nucleus delineation and rotation. But we could not see what is happening actually in terms of morphologically, and how do we create the waves in these cases. You can see this is the hydro dissection has happened, cortical cleaving hydro dissection, with the amount of distance from the posterior capsule to the nucleus, epinucleus can be measured on table also. And you can realize this requires an immediate attention to decompress. Or you can see it is complete or incomplete, can also be customized also. Accordingly, you can judge the surgery well. So this is the delineation happening in this case. We already had done a hydro dissection. This is the one cushion we have created, and this is the second delineation being done. So you can customize the epicortical cushion in cases of weak posterior capsule, like a posterior polar cataract or a post-vitrectomy eyes where you have the thinking of posterior capsular damage. So this is what we are working on now, to actually look into a volumetric analysis of incision dimension. Normally you have you use various devices to measure the incision, you can say dimensions, which doesn't give you a volumetric change after each step of surgery. And this is what we look for: IOL placement, the distance from the posterior capsule to the posterior surface of the IOL, and how it changes when you decompress or increase the pressure. Does the IOL also shift, which is normally seen in those cases of a larger volume capsular bag, like high myopes. Your lens can shift, and this have a huge can say value in cases of toric implantation or a trifocal toric lenses. The future area which I'm looking for young people should look into advanced IOCT. We are doing a volumetric analysis, the own three-dimensional volumetric analysis, especially after using the various injectable devices. And which injectable devices would cause more distortion of wound is a important area to look into. And the damage which happens during phaco surgery, especially the hard cataracts, that damage can be analyzed subsequently in terms of morphological analysis. You can use a confocal microscopy to see actual orientation of collagens and the activity, characteristic activity happening in that area. Does it translate into a significant astigmatic change subsequently as per the healing happening in these cases? So that can be graded and can be looked into subsequently also. The other area of work we have done is the difficult cases. This is our work in intermittent white cataracts, where we could classify the white cataracts based on an IOCT picture and change the approach as per the picture we see in these cases. So we would classify them in 4 categories. Type 1, we had uniformity, type 2, type 3, and type 4, depending on the configuration of anterior capsule, the cortical hydration, and clefts. So if you look into that, this is a type 1 type of cataract, which you normally see in an older age group patient, where you have a uniformity of convexity of anterior capsule and uniformity of hydration of cortical fibers and liquefaction. So there is hardly any liquid pockets in this patient. Therefore, when you initiate the capsular rhexis, you don't have any chance of rhexis being extended to periphery because there is no significant pressure from inside out. So this raised lenticular pressure is hardly there in these cases. So you can customize your rhexis as per the requirement for these cases. Type 2 is the one which was classical cases of a raised intralenticular pressure, where you have a hydrated sheets of a cortical fiber going across the entire length of anterior convexity of an anterior capsule, and the pockets which are there, they are intermingled between the fibers. You can understand this fiber will not allow the fluid to come out when you actually initiate the capsular rhexis here. You can see I've initiated the capsular rhexis, the fiber tend to bulge out because of intralenticular pressure, but the pressure doesn't get released. So these are cases where you're going to have the chances of extension happening in these cases. So you have to approach differently these cases. So this is a small video to show the same case here. As soon as we initiate the rhexis here, which normally we'll do a smaller rhexis, we could morphologically see this was a type 2 cataract. The bulge is happening. So we'll initiate the injection of a dispersive viscoelastic, then subsequently remove the hydrated cortex with the bimanual. These cases will not be amenable to a needle aspiration as such. Therefore, the pressure has to be decreased by aspiration of cortical fiber. You can see the convexity has gone into concavity and the pressure has gone down, and it could do a good capsular rhexis in these cases. Type 3 is a combination of type 2 and type 4. So these are a sort of a gamut of a spectrum of white cataracts. So you can see here you do have area of hydrated cortical fibers, but these clefts are also open. As soon as we make a nick, some sort of fluid will come out. You can see a turbid fluid comes out and pressure goes down and concavity comes up in a capsule. That means your pressure is now balanced. More pressure in the antechamber than the interlenticular pressure. Rhexis can be initiated very safely in these cases. Type 4 is towards a hypermature cataract or Morganian, where the milky fluids comes out and your things become simpler. So IOCT gives you actual dynamicity of capsular puncture, what you do, or initiate capsular rhexis, and what happens during that. Accordingly, you can modify your surgical steps. In fact, this work has been appreciated all across the world by various peers, right from American Academy to APACRS to AIOS, giving us award and publication of these. Same for a posterior polar cataract, where you could classify, picturize them on the table. So this is an open posterior capsule in a young patient. These are type 1, type 2, and type 3 type of posterior capsular posterior polar cataracts. Accordingly, we can customize our surgery in terms of leaving the cushion. So we need to assess few things. One is the clarity of delineation of posterior capsule across the length of a posterior polar disc, which is very, very important. If you can clearly delineate the posterior capsule beyond the disc, Then it is a type 1 where you can do a routine surgery as such. Type 2 is one where you can delineate the posterior capsule in the periphery, but central area where the disc is there, the delineation of posterior capsule is not very clear. So this means two things. One is your posterior capsule may be weaker or not effectively there, or your disc is so dense that it creates a shadow there. So larger the disc, higher the disc in terms of size wise, you're going to have a more chance of posterior capsular damage. Similarly, type 3 is more denser, therefore no delineation of an entire posterior capsule in the entire range of a disc in these cases. So what we do in these cases, type 1, we do both hydrodissection and delineation because we could see the posterior capsule intact in these cases. So type 1 is easier. You can see there is a delineation being done, and subsequently dissection is also done. Delineation and dissection. The surgery is simpler, faster, and you can maintain the posterior capsular integrity. This is after we remove the nucleus. You can see still the epinucleus is well intact. So this is a savior for a posterior capsule. And you can see intact posterior capsule also. Type 2 and type 3 where we don't do delineation. So you can see this is we do delineation only. We don't do hydrodissection in these cases. You can see after the nucleus emulsification, the cortical complex, that is epicortex and cortical complex, is still there till the end. Sometimes where you don't want to do a hydrodissection, it can happen inadvertently. That can also be picked up by IOCT. Accordingly, you can customize your surgery. You can assess your posterior capsule at this stage and complete your surgery subsequently. So this is the advantage of IOCT picturization, and you can modify your approach for surgery. The type 2, which has type 2 and type 3 will have a higher chance of posterior capsular dehiscence happening, which is true in our series also. Type 1 is hardly everything is normal as such. The IOCT will give you a customization for what type of hydro procedure you have to do and what type of nucleotomy pattern you have to do. Type 3 is slightly harder nucleus. You may have to do a proper nucleotomy techniques, while type 1 is a softer cataract. You can do a routine chip and flip technique also. So research in future, apart from IOCT giving you all these steps for modification, hydrodissection or no hydrodissection, you can look for a posterior capsular assessment right from the beginning of your step, right from your hydrodissection delineation to the end of your surgery also. So if I look into the various applications, as I talked about on-table measurements of various area of concern, classifying the tough cataracts like a wide cataract and posterior polar cataract, then looking for a risk of a PCR or a posterior capsular dehiscence happening in difficult cases. Then ultimately looking at wound architecture and its effect onto the damage happening to the collagens at that area and subsequent change in the refractive astigmatism of these patients. And especially the toric IOLs, if you could assess the stability of IOLs with IOCT, that will help us in customizing our IOL position subsequently in these cases. So these are 4 important areas which really helpful in IOCT microscope as well. So I would say future is there for a better IOCT microscope which can give a much higher resolution to see every structure of a cornea to a posterior capsule. And also it should have a good tracking system, which is lacking at this stage. Tracking has to be there, and it should also give you a comprehensive assessment of other you can say ancillary measurements, like you should have other areas of concern can be taken care of during your surgery as such. The instrumentation is difficult because once you take a instrument which you do use nowadays, it casts a shadow, so you can't see beyond that instrument. Therefore, we need to have an instrument which are compatible to IOCT microscopes. And I'm pretty sure in future we'll have more research into this to have a better acceptance of IOCT microscope. Thank you, Rohit, for getting me into this program.